From the introductory video, you should now understand how much may be at stake for your practice. In this section, we'll cover some basics of quality reporting. There are over 280 measures that have been approved for reporting to CMS and a variety of ways you can report. MSOC Health has developed this YouTube series to assist you in understanding the options and selecting what will work best for your practice. First, we want to cover some basic concepts that will be helpful as you move through the series. It's important to know who in your practice must participate. The PQRS program requires virtually all providers who bill Medicare to report quality measures to CMS. It doesn't matter if you see mostly inpatients or mostly patients in the office. If you're not paid under the Medicare physician fee schedule, for example, rural health clinics or federally qualified health centers, or if you are participating in a Medicare Shared Savings Accountable Care Organization, you're not required to report quality measures through the PQRS program. ACOs do have a quality reporting component, but it is done through a different process. PQRS is a provider-based program. Quality measures are reported and penalties assessed at a TIN and NPI level. This means that if a provider works at two practices with different TINs, she will need to report quality measures at each practice. It also means that it's possible to have one provider in a practice who participated successfully and gets the full Medicare allowable amount as payment, while a second provider who did not participate successfully receives a lower reimbursement rate. Penalties are always 2 years behind. Reporting in 2014 will impact payment in 2016. Historically, PQRS bonuses have been based on whether the provider reported on the quality measures rather than on how they performed. To understand the difference, let's look at one quality measure. Measure number 226 is one that can apply to almost all providers. It measures the percent of patients that have had tobacco use assessed and appropriate counseling provided. A high percentage indicates higher quality. Each measure has a frequency. Sometimes the measure is to be reported every time a qualifying service is provided. For other measures, like this one, the measure only needs to be reported once per year, regardless of how many times the patient is seen. Often, providers will choose to report for every visit in order to ensure that it's not missed. This is fine, only the data for the last visit in the year will actually be counted. Next, each measure will have a denominator definition. In this case, it's the number of Medicare fee-for-service patients who are over age 18 and were seen by the provider for a standard outpatient office visit during the calendar year. The measure specification lists the specific CPT codes that will cause a patient to be counted in the denominator. For other measures, the denominator definition will also include a set of diagnosis codes. Both ICD-9 and ICD-10 codes are listed. When the measure definition includes a diagnosis code, it's important to understand that all patients that have that code listed in any position on the claim will be considered eligible for this measure and counted in the denominator, even if the specific diagnosis code is not the primary diagnosis for the service provided. Quality codes, often called CPT-2 codes, are used to report on the activities being measured. In this case, you will report 1036F if the patient was assessed as a non-smoker, so no counseling is needed, and 4004F if the patient is a smoker and you provided some form of cessation counseling. If there was a medical reason why counseling wasn't provided, you would add a modifier 1P, and otherwise, whenever no counseling was provided to the smoker, you would enter 4004F with an 8P modifier. CMS will calculate two rates, the reporting rate and the performance rate. To understand the difference, let's look at an example. A provider saw 1,200 Medicare patients during the year. Each patient may have been seen multiple times, but they are counted just once. In our example, all of them were over the age of 18, but 200 were actually covered by a Medicare Advantage plan. Only Medicare fee-for-service patients covered by traditional Part A or Part B coverage are counted. So the denominator for this example is comprised of these 1,000 patients who had at least one standard outpatient visit during the year. Quality codes recorded on these 1,000 patients are shown here. The reporting rate is calculated by identifying all patients with any quality code recorded, 750 in this example, and dividing by the denominator for a total rate of 75%. The reporting rate doesn't indicate that you provide high quality, just that you reported a measure on 75% of the eligible patients. The performance rate is what actually determines the level of quality provided by this physician. It is based on those patients for whom a quality code was reported and whether that code indicated high quality. In our example, there were 750 patients with codes reported, but 10 of these were not canceled due to medical reasons, so the denominator for the performance rate is 740. The numerator is the number of these that met the quality parameter, 1036F or 4004F, or 600 out of 740, which is 81%. In 2014, performance rates on all measures reported must be greater than 0. Now, it's hard to get a 0% performance rate unless you choose a measure where you have a very small denominator. In this example, if you reported 40048P on all patients seen, you would have a 100% reporting rate, but a 0% performance rate. Under the value-based modifier program, when it's fully implemented, the performance rate will be compared to a national mean for your specialty and will be one component used to determine whether you receive payment cuts or payment increases. The value-based modifier program applies to practices with 10 or more providers starting in 2014 and is expected to be expanded to all practices next year. Now that you've got the basics, you're ready to move on and understand what you need to do in 2014 to avoid penalties in 2016. You have numerous options. That's good because it allows you to tailor your approach to your providers and your current workflows. But it's also problematic because it adds a lot of complexity. We've designed this series to provide a roadmap and allow you to select the route that will work best for your group. We recommend starting with the overview for your size practice. This provides a brief summary of the reporting options and will help you identify which other videos you'll find valuable.